Hello and thanks for joining us for Healthline. I'm Jamie Ostroff, and today we are talking about male infertility. Dr. Jared Moss with Regional Urology is going to be here with me taking your questions for the next half hour, and we want to encourage you to ask what's on your mind. I know it's a difficult topic, but as Dr. Moss says, it's pretty common. So if you are online, just click on the Healthline 3 box halfway down the right side of your screen. Type in your question, then send it to us, or you could just give us a call. The number is right there on your screen, 318-219-4569. We'll be taking your questions until 12:30. First of all, thanks so much for joining us.
Thanks for having me. Appreciate it.
So if you could kind of put the issue of male fertility in a nutshell, is that even possible? Just to kind of sum up, what do you typically see?
Yeah, so I think the biggest concern we see people come in is, hey, my wife and I been married, we've been trying for 6 to 8 months. We haven't had any luck. She's not been pregnant, so, want to come in and get an evaluation. That's a good scenario. We were talking earlier, some of the troubling scenario is, hey, we thought it was my wife or significant other or girlfriend, whatever, and we've been working with her over the last 2 years. And we thought it was her the whole time, and then finally we got a semen analysis, and there's some problems there, and they think it might be me. Now we're here to talk to you and find out what to do about it. So, it involves, basically a checkup. A lot of times people say, well, what does it mean? I mean, what is a male fertility evaluation? And so people can come in. I do a history and physical exam. I talk about the male history. We find out if there's risk factors or things that we should be concerned about. One of the biggest things that I see is that guys will come in and they've been on testosterone, and they don't know that it impairs sperm production. We see that so many times, and maybe the doctor or the provider that put them on testosterone may not have known that fertility was a concern, and they may or may not have mentioned that it impairs sperm production. So a lot of times guys that are on testosterone will have no sperm counts, and it's because of the medication that they're using. So sometimes that's an easy fix. We look for other causes. We look for hormonal abnormalities. We look for varicoceles. Those are large dilated veins around the testicles that can sometimes cause fertility issues. So there's a multitude of things that we go through to try to figure out what's wrong and then what can we do to help.
So when someone comes in to get evaluated for infertility, what does that entail?
So a common question people have a lot of time is, do we need a referral? And the short answer is no, you don't have to have a referral. And they'll come in and they'll make a call and say, hey, we need to get a checkup. We'll set things up. They'll come in, we'll get the history, physical exam, we'll get the hormones, and then we'll set them up to do semen testing. A lot of times I ask that men get 2 semen tests. The reason we ask that men get 2 is it's very common to see abnormalities in at least one parameter in a semen analysis. There's probably 10 or 15 different things that it looks at. So if you come back to see me and there's an abnormality and we go, well, we're not really sure if this is real or not, we need to repeat the test. So a lot of times they'll say, hey, let's go ahead and get 2 of them so we can put them side by side when you come back. And that way if you have a bad day, because sometimes the semen parameters in men will go up and down to see, is there really an issue or did you just have a bad day?
So there's a lot of different things you can determine from that test. What are those things that you look at in a sperm sample?
So it's quite a bit. It looks at the count of the sperm. It looks at the health of the sperm. It looks at the shape of the sperm. And there's a multitude of things, and those all have to be taken into context, because sometimes one isolated abnormality may not be clinically significant, but if there is a severe abnormality, that could be significant, or if there's multiple subtle abnormalities, that can be significant. And sometimes people will say, well, isn't just getting a semen analysis enough? Do you really need to come in to actually get a checkup? And in my opinion, no. You need to come in and you need to talk to a physician. You need to have somebody lay hands on you. It's rare that infertility presents as cancer, but a lot of times men that have lymphoma or leukemia or even testicular cancer will have low sperm counts as a byproduct. And I probably find 1 to 2 people a year that come in for an infertility evaluation, and lo and behold, they had a malignancy, and that was the reason that they were having problems with fertility. The fertility wasn't the issue, it was a byproduct of the cancer. So it's more than just doing semen testing.
And you mentioned some of the risk factors that might lead to infertility. Tell me about those.
Yeah, so some of the other risk factors, if people have unusual exposure to chemicals, hormones, if they've ever been treated with chemotherapy or radiation. And I think the big one here locally that people miss all the time is being on testosterone. And people are like, well, that doesn't make sense. Giving me more testosterone, wouldn't that help my fertility? The problem is the brain can't tell the difference between the testosterone that men make naturally from their testicles and testosterone that's injected. So if you give yourself an injection of testosterone, the brain perceives it as going, wow, that's a lot more testosterone than I really need to make. So the body's response to that is to turn down the signals that the brain sends to the testicles. Thus, if the brain stops sending signals to the testicles will stop making testosterone, but as a byproduct, they stop making sperm too. So that's one of the reasons why sometimes men that are on testosterone will have testicular atrophy or shrinkage of the testicles, because the brain doesn't need to send signals to the testicles anymore because you're giving it exogenously or giving it outside the body.
And let's talk about how common this is. I know infertility is a very difficult and uncomfortable subject for a lot of people to talk about, but it's quite common.
Yes, that's the thing that just kills me when I see people come in, because I mean, this is what I do. It's one of the primary things that I do. So I see it all day, every day. And every couple that comes in kind of feels like, hey, they're the lone wolf here. They're the only one that's going through it. And a lot of times I'll talk to them that 1 in 6 couples at some point in time are going to struggle with infertility. And that's a big eye-opener for a lot of people. And the reality is there's a lot of people that are going through fertility struggles. They're just not verbalizing it. They're not talking to their siblings, their friends, their cousins, their family members, because I think the reality is if we talk about it more, we'd actually realize, whoa, there's a lot of people that are going through the same thing. So one thing I'm always careful is anytime I see a couple that's married or something like that, I don't ever ask like, hey, when are you going to have kids? Or when are you guys going to have kids? I just assume they're probably trying, and if they don't have kids, there may be a reason why. There may be some fertility concerns.
So is there a way to approach that, or just, they come to you eventually?
I think it's tough. I guess I'm just much more aware of the issue that I try not to always inquire about, hey, when are you having kids, or when are you going to have more kids? Because for people that are going through infertility issues, that's the one thing they dread. They hate going and having to re-answer and explain the situation. Yeah. Well, maybe, we're working on it. And in reality, it can be, very stressful for a marriage, their relationship. It can be a financial burden. A lot of things in fertility are not covered by insurance. Some things are. So, I mean, it's a multitude of emotional stress, financial stress, and things that if patients have seen me, that I kind of refer to it as the fertility gauntlet. It can be quite tough. So, I mean, I'd love to see, I try to encourage people to reach out to support groups and stuff like that when they're going through it, because it can be really tough.
What type of support is available for people?
I don't know. It's tough because it's such a private issue. There's still not, I've talked about it with a lot of my patients, and I was actually talking about it with one of my patients the other day about trying to get a support group together, and would people be willing to come to a support group. There's not one that I know of locally that I'm aware of, but I'm sure there is, certain things that are going on, but there's nothing that I'm aware of. But there are things online, there are things nationally that reach out for support groups and things like that we can point and direct people to. But man, it'd be awesome if we could ever have a local support group for people to come and sometimes just share their stories about what they're going through, or we tried this, or this worked for us, or didn't.
Yeah, and how does talking about it help?
Well, I think it's tough because I think anybody that tells you stress is such a big part of it. And it's like a snowball effect, right? So you're not having the pregnancy that you want. And we live in this society, right? It's instant gratification. We plan, we delay things, we do school, we have our career. I'm going to get married, I'm going to have children. Everything's on this controlled time schedule. And then all of a sudden, that's one thing we can't control. And when we start to not be able to control it, every month that goes by where there's not a pregnancy, there's more and more stress. And a lot of times guys will have erectile dysfunction. They can have ejaculatory issues. And then, a lot of times I'll explain to the spouse, hey, it's not that he doesn't want to have a child. It's just sometimes this is how men respond to some of the stress. These are things that we deal with. And I think sometimes it's helpful from a counseling standpoint to just let them know that there are things we can do to help. And he's trying to lessen the stress on both sides. And even sometimes, couples will say, man, we're just going to take a break. We're not going to worry about anything for 6 months, and then somebody ends up getting pregnant. So there's just, stress is a big component of fertility.
Yeah, how does stress play into the equation?
Well, I think it's a little bit tougher to say that, quantitatively for men. I know from a man's standpoint, if they're very stressed out, a lot of times they'll manifest as erectile dysfunction or ejaculatory issues. I don't necessarily see it manifest in sperm counts, but for women, it can be very tough for them. If they have a lot of stress, they may not be able to ovulate. And if they can't ovulate, it doesn't really matter, right, if they're not able to produce an egg. So both of those, can contribute in a very significant way that I think sometimes people on the outside don't realize unless you've been through it. And when you've been through it or you're going through it and you're like, yes, I know what he's talking about. We've been through it. My husband's had those problems, and, it was very frustrating, and, we're having lots of issues, and then it was like some of the things were just adding injury to insult.
Yeah, and we were talking about how common it is. What is the commonality among men versus women? We hear a lot about women in media, every time you see in a movie or a TV show a couple trying to get pregnant.
Right.
So it always seems to fall on the woman, the way the script is written.
Well, and that's the way it's always been traditionally, and that's the one thing that we're always trying to change. And my big message to people is anytime there's a fertility concern, both partners need to be evaluated simultaneously. And we say up to 50% of the time, a man is involved in some form or fashion, whether it's an ejaculatory issue, erectile dysfunction, abnormal semen parameters, something going on. It's a large, large portion. Yes, women can certainly play a part in it too, but it's still not enough that you don't ever go down the process of saying we're going to evaluate the woman first, and then we'll evaluate the man after we've evaluated the woman if we've put her through certain things. Because sometimes if there's a significant male factor, it may limit a lot of the things that you're doing with a woman and may not have to put her through those tests, which may be invasive, which may be expensive, things that are unnecessary. So it's just common sense. The man and the woman both can be involved in fertility issues, evaluate both people at the same time, and it'll be a much better guide to direct you. What are the next necessary steps? What's the overall prognosis? Let's make sure that we're not doing things that are unnecessary.
And we've talked a lot about identifying the problem and finding the problem. How do you treat male infertility?
So, that's a loaded question because it's very complicated.
We've got time.
It's a number of things. So, like for instance, let's say a common one is men come in on testosterone, and sometimes they may come in and they may have done a semen analysis outside and it shows that there's no sperm in the ejaculate. So that's a big problem, right? They're kind of freaking out, and so they come in and I'll say, well, are you on testosterone? They say, yeah, he's doing testosterone injections, and I'll say, well, that's the problem, as we've discussed, that it's impairing your sperm production. I say, it's okay. Most of the time that's reversible. We just need to get you off the testosterone. Clomid is a medicine that's a lot of times used in women. You may or may not be familiar with it, but it's a medicine. It's an estrogen blocker, and it helps women to ovulate. But an estrogen blocker can also be used in men, and it helps them to produce more testosterone naturally. So without making it too complicated, it blocks estrogen feedback to the brain so that the brain increases the signals to the testicles and asks the testicles to make testosterone, and as a byproduct, sperm. So a lot of times in those men, it may take around 3 months for them to start to recover their sperm parameters when we'll start checking semen parameters. But we've had lots of couples that we've been able to help have sperm return to the ejaculate in men, and then they go on to have a natural pregnancy, and that's a nice solution. We find that.
Relatively simple too.
It is, and those are nice to find because sometimes it's not always that easy. Sometimes men will come in and, we said that a semen, analysis looks at like 10 to 15 different variables, but you'll come in and their counts are a little bit low. The motility as far as how well the sperm swim are low. They've got a history of infertility. They've been trying for about a year. And I always ask, it's important to ask about the female evaluation too. If it looks like for the most part, they're saying, hey, they've checked my wife out. There's not really any problem. She's ovulating. She doesn't have hormonal issues. And we looked at it seems to be an isolated issue in the man. One of the things that we'll look for is a varicocele. And varicoceles are dilated veins that are common on the left. They're present in about 15 to 20% of men. So just because you have a varicocele doesn't mean you need to have it fixed or it's dangerous. But sometimes if they're large, they can cause fertility issues. And we think that the most common belief is that it causes congestion of the testicles so that the blood flow comes in, but it doesn't get out quite as well as it should. And so without being overly complicated, it creates an environment that's not ideal for testosterone production and sperm production. So a varicocele repair is an outpatient surgery to basically go in and you tie off the large dilated veins to kind of help reroute the blood flow from the testicle. And over time, a lot of times those men will see improvements in their semen parameters. So those are a couple of different things, that we can evaluate. Sometimes men just have low testosterone. And so there's other things that we can evaluate and say, hey, if we can hormonally optimize this man, we may be able to improve the sperm parameters, but you just have to make sure you're doing it in a fertility-friendly option. As we said earlier, you can't just put a man on testosterone because that's going to do the opposite.
Right. Just if anybody's just joining us, explain again how taking testosterone might not always be the best option?
Yeah, so it still blows my mind how common it is that people are taking testosterone and they're not aware that it basically suppresses sperm production. Because when you give testosterone to your body, either through a gel that you put on the skin, a testosterone injection, that the brain can't tell the difference between the testosterone that the testicles make naturally and what you're given outside that's an unnatural form. And so when you give yourself a testosterone shot, the brain perceives that as being way more testosterone than is actually needed. So it shuts down the signals that it's sending to the testicles. And so over time, the testicles are atrophy, and then, the testicles are not making testosterone, and as a byproduct, they're not going to make sperm. Thank goodness most of the time that's recoverable. It's just not guaranteed. So even when I see young men, like let's say men that are 30 years old and they have symptoms of low testosterone, which we've talked about some of this before, they've got fatigue, low sex drive, erectile dysfunction, difficulty concentrating. There's a lot of symptoms that fall under low testosterone. You check their testosterone and it is low, and they come in. One of the first questions I'll ask them is, do you have fertility concerns? Because if you said, yeah, I do, then we talk about Clomid and some other options that are fertility friendly, as opposed to just putting them on injectable testosterone. We try to avoid that in people unless they say, no, I'm 45, I have 3 kids, I had a vasectomy. Clearly that's not somebody that's worried about fertility.
Right. All right, we are a little over halfway through this health line. We're taking your questions for about another 13 minutes. We'd love to hear from you, your questions about male infertility with Dr. Moss here from Regional Urology. The number to call is right there on your screen, 318-219-4569. And if you're watching this on the web, you can also submit your question by typing it on the right-hand side, about halfway down your screen. Just click on that little box there. Meanwhile, we've talked about all of these treatments. How does insurance help with that, or is it covered by insurance?
So that's a good question. So most of the time, the evaluation is covered by insurance. If you had a varicocele that's a man, that's what we talked about earlier, sometimes those can cause fertility issues. That is a surgery that's typically covered by insurance. And I say typically, it's rare that I see somebody that has an insurance denial. So thank goodness most of it is covered. The hormones are usually covered by insurance. But a lot of the other more advanced fertility procedures are not. Like for instance, if a couple needs to do insemination or they need to do in vitro fertilization, most of the time there's not coverage for that in the state of Louisiana. What that's going to be 5 to 10 years from now, we don't always know. There are lots of other states in the United States that do have fertility coverage. So it's kind of an evolving deal to see what states are going to have fertility coverage, when are they going to have it, how much fertility coverage do you have. Some people's insurance, they do have fertility coverage. It's just most does not, because it's certainly not mandated. So if you had that, you would be one of the lucky people to have fertility coverage. And then, of course, things that are not covered that are covered outside of insurance, meaning it's not covered by the insurance, depending on the type of procedure and things like that, they certainly can be expensive. So, that's part of the struggle and the stress for people that are going through it, is because there's a big financial component to it as well.
So you're really, as a doctor, you're not just treating a medical issue, you also have to kind of take care of the patients. I'm sure that bedside manner really does come into play.
It is. I think you have to be sensitive to the needs of these couples, and there's I mean, usually, unfortunately, a lot of times by the time the couples make it to me, because I'm one of the people that specializes in male infertility, I mean, some of these people have been put through the gauntlet. I mean, you can sense it as soon as you walk in the room, the tension that's there and the stress that's there. And I remember that was one of the things that was always so amazing to me, is to think about how stressful a cancer diagnosis is, or just other things that we go through in healthcare. But when you compare that to some of the couples that are having some of the fertility issues and the struggles, I mean, it's right up there with anything else that people are going through. And certainly the people that have been through it will tell you it weighs a lot on, you know, your emotions and you know, your finances and the health of the relationship and things like that.
All right, on that note, let's talk about a success story. You know, talk about, you know, maybe a particularly challenging case that you've handled and have been able to solve.
Yeah, so I mean, there's lots and lots of success stories. One of the couples obviously would not use their name.
Sure.
But I had seen him initially. It was when I first got into practice in 2016, and they were one of the couples that had been put through the gauntlet, and they had told him they were just going to have to adopt, and you know, that's probably it. There was nothing else that anyone could do. And so he came to see me, and he had some semen testing done, and it showed that he had no sperm in the ejaculate. I'd gone through his history and examined him, and I noticed that on his semen testing, which is very important, that his volumes were low on all of them. And so, without being overly graphic, but I had asked him if that was what he felt like was a consistent lifelong problem for him, was that the volume was low, and he said that it was. And so I was concerned that he may have an obstruction somewhere, and that he's producing sperm, it's just not making out of the body. And so we had to do a special test on him to evaluate his seminal vesicles, but he basically had an obstruction at his ejaculatory duct, which is pretty rare.
How do you locate that?
Unfortunately, it's with an ultrasound. And so it's not common that we have to do that, but we did an ultrasound of the area, and we could see that the area of the seminal vesicles were very, very dilated. And so we used a needle, and we were able to go in and we aspirated some of the fluid off, and we looked at it under a microscope, and we saw that there were lots and lots of healthy sperm there. So we were like, this is awesome. This is a game changer, because they had been told there was no sperm and there was no hope, and then we knew that there was sperm there. So then we set him up. The couple ultimately had to do in vitro fertilization, but I did a separate procedure where I went into his testicles, because I knew that he had sperm there. At that point, we were able to get we were able to get sperm out of the testicles. They did in vitro fertilization with Dr. Vandermolen here locally, and they have a kiddo that's biologically theirs. So that was kind of an unusual circumstance for a couple that, you know, really turned out to be a great success story. We have other people, sometimes I do vasectomy reversals as well. So there's, you know, couples that come in and, you know, depending on the circumstances, it could be a second marriage or it could be a change of heart. And the man has had a vasectomy, and we've had several couples that go through and they get a vasectomy reversal, and then they're able to have a kid. And it's always neat, because I always make sure to tell people that, you know, we do care about you. It's not just about the surgery. Like, we want Christmas cards, we want pictures, we want you to bring the kids back to the office. So it's always really cool for me to get like a card in the mail that's a birth announcement and go, man, that was really a special deal, you know, to be able to help somebody out. So
yeah, I bet you got a lot of those.
I wish it was more. I wish that it was more than we get, because you obviously want to be able to help everybody. Sometimes you're not able to, but it is a nice reminder for why you do what you do.
Yeah, what kind of joy does that bring you when you see the results in a new person?
Yeah, I mean, I don't know. I mean, it's probably one of the most satisfying things you can do, because I mean, I don't, as a parent, I don't know if there's anything greater than a kid. And so for to be able to give that and help somebody achieve that, that's you know, I don't really know how to put that into words. I mean, it's obviously very special.
Do you form partnerships also with gynecologists who you know, maybe work with women?
Yeah. So like when I first got to town, I started work here in 2016, and I went to essentially all the gynecologists in town and said, hey, I'm you know, one of the new urologists in town. I specialize in male fertility. I just want to be here. I want to help get the men evaluated. And for them, sometimes I think it's a big help, because they're not trained in how to evaluate the male. They're not trained in how to interpret the results. They're not trained to know what's important for the male, what's not important. And so for them, I think it was a big help to say, hey, we're all working here as a team, and is the gynecologist or the obstetrician are going to be evaluating the female. But as far as the male, we're going to get you to see, one of the urologists, and they're going to take care of the male portion, and we're going to work together as a team to try to make sure that the obstetrician is addressing the female needs and the urologist is addressing the male needs, and that way both people are getting exactly, what they need.
Yeah, a lot of collaboration there,
Yeah,
I'm sure.
there's a lot of
Very
overlap,
important.
but yeah, all of the folks in town have been very, very willing to help out and willing to participate. And Dr. Vandermolen and I share a lot of patients, and we work together very closely on couples that are have tried maybe conservative things and they're looking towards insemination or in vitro fertilization, and working through that process with those couples.
We've got about 4 minutes left in today's Healthline 3. I know you and your colleagues from Regional Urology are frequent guests on this program. Let's talk a little bit more about the different types of services the clinic offers, because we've had lots of different specialists with Regional Urology.
Yeah, so I think the biggest thing that we always like, that one of the things that I like the most about our group is it's kind of a one-stop shop, and I have patients tell me that all the time, that we have our own lab there, we have our own surgery center, we have our CAT scanners, we have our own MRI, we have a radiation center, we have a cancer center. All of that is there on one campus. And so it's nice when we talk about from women with what we call female urologic conditions, such as leakage of urine or urinary tract infections or kidney stones, or men with BPH or erectile dysfunction or prostate cancer. All of that, we can service under one building. And because we have multiple urologists, we kind of try to divide and conquer. We'll have certain urologists that work primarily with females on female urology issues. We have certain urologists that will work primarily with men's health. We have certain urologists that are working primarily with kidney stones. We have certain urologists that are working primarily with cancer. So we can get anybody into the door and then kind of figure out where is going to be best for you to see. Is this a complicated issue and you need to see more of a specialist? Is it a routine issue, like maybe you just have a urinary tract infection, and of course anybody can take care of that. We have several PAs that help us, and it really facilitates. We're almost always can get patients in same day, which is pretty hard to do sometimes.
Wow.
To be able to call a specialist. You don't always need a referral. That's one of the things we try to emphasize, is that some of that's insurance dependent, but most of the time you don't need a referral. You can call and say, hey, I've got a concern, I need to see somebody, I want to get this checked out. If you have a certain provider that you want to see, it depends on their schedule. It may be a little bit of a wait. If it's an urgent issue, we can usually always get you squeezed in with somebody to figure out what's going on and then get you to the best person who's going to be best suited to take care of you.
So you're always taking new patients?
Always. Yeah, we try to, we always have our clinics blocked off to be able to, you have to be able to take on new patients to be able to make sure that we're taking on new problems, and that new people with issues can get in the door, because once you've fixed somebody's problems, you have a lot of other people out there that still need help.
And how have you seen, just very quickly, how have you seen technology in the field of urology advance over the course of your career?
It's crazy, and I'm still very early in my career, obviously, but it's always changing. We're always trying to stay up to date. One of the newest things that we've got is a 3T MRI. That's been a big game changer for surveying men with elevated PSA, prostate cancer, doing MRI fusion biopsies. It's been just very up-to-date quality imaging that a lot of times people are having to travel to Dallas, Houston, New Orleans to get, but we can provide that here.
All right, so we've got about a minute left. Let's tell people how they can find you and your colleagues and get in touch.
Yeah, so our telephone number is 683-0411. That's a 318-318-683-0411. Our website is regionalurology.com. We actually have a new number that we've been promoting. It's 318 Urology. So sometimes that's a little bit easier to remember. You don't always have to have a referral. Give us a call or find us on the website, and we'll be happy to see you and take care of you.
And where are you located?
We're located at 255 Burcoons Industrial Loop. We're right off of I-49. You can't miss us.
All right, we've got about 30 seconds left, so I want to give you the floor just to kind of make the one final pitch to men going through, just to let them know they're not alone.
Yeah, so I think the main thing is for women and men, number one, you're not alone. It's 1 in 6 people that are going to go through it at some point in time. It's okay to talk about. It is normal. There's a lot of things we can do to help. Don't struggle alone. Come in and get evaluated, and we'll try to help.
All right, Dr. Moss, thank you so much. Y'all have a wonderful afternoon and be well.
Thanks.